Okay, so this paper's title is The Great Immune Escape, Understanding the Divergent Immune Response in Breast Cancer Subtypes, written by Sayali Onkar and their colleagues. So to start, I'm going to introduce the classifications of breast cancer. It's divided into two classifications. The first one is the histological one, which is divided into two types: the lobular carcinoma and the ductal carcinoma. The lobular carcinoma is associated with poorer patient outcomes. This is based on the cell appearance and their behavior. Now, the second type is the molecular breast cancers, which are based on the receptors that are expressed on the cancer cells. The three types are the HR positive or hormone receptor positive, the HER2 positive, the human epidermal growth factor receptor, and the triple negative breast cancer. The ER positive is further divided into the luminal A and luminal B. Luminal B is associated with poorer prognosis than luminal A and greater tumor growth. The HER2 positive is divided into luminal B and HER2 enriched. HER2 enriched is HR or hormone receptor negative. Luminal B is hormone receptor positive. And the final breast cancer subtype is the triple negative breast cancer, which is negative for all receptors and has the highest tumor grade and proliferation. And so the current classifications of breast cancer only look at the receptor status and overlook the interactions within the immune system and the complex microenvironment that surround the tumor. Current immunotherapies mainly use immune checkpoint inhibitors, which target immune checkpoint agents like PD-1 and PD-L1. However, even though they have showed some promise benefit, they do not have the very high overall response rate yet, or survival rate. And therefore, it is necessary to have a comprehensive understanding of each breast cancer subtype, looking at the interactions not only within the cell, but between the cell and the immune system, in order to ensure effective immunotherapies and better patient outcome. So the objective of this study was to compare and contrast the complex interactions between immune cells and all the breast cancer subtypes on a histological and molecular level, and to discuss how this knowledge applies to future opportunities for treatment. And so the first section of this paper discusses the intrinsic factors that are associated with the tumor microenvironment, the tumor immune microenvironment, or known as the TIME. So, for example, for the triple negative breast cancer, this paper highlights the subclassifications within this type that look further beyond only the receptors, but also at, for example, the basal-like type, which is characterized by an immunosuppressive response and therefore is best treated by chemotherapy. Or, for example, the immunomodulatory, characterized by high tumor infiltrating lymphocytes and therefore best treated through immune checkpoint therapy, and other subtypes as well. So the classification beyond the receptor status has been proven to be associated with better prognosis for the patients. So one way to classify these beyond the receptor is to look at gene modules, or set of genes that are expressed simultaneously within the cell. So, for example, if we compare the HER2 positive with the other subtypes, we would notice that this subtype has more proliferative signaling pathways with respect to the others. For example, the HR positive has more tumor necrosis factor signaling pathway, apoptosis, and hypoxia, while the triple negative breast cancer is characterized by cytokine and interferon signaling pathways and secretions. And so these particular classifications can help us target each subtype distinctively and with a greater efficacy. Another way is to look at the tumor mutational burden, or the amount of the mutations that lead to the expression of neoantigens in each cancer cell. So with respect to that, triple negative breast cancer had the highest level of tumor mutational burden, followed by HER2 positive, and then finally HR positive. And this leads to an antigen-driven immune response. And this is why we will see later that the triple negative breast cancer has the greatest immune reaction. Another way is to look at the human leukocyte antigen, whose downregulation leads to an immune escape, because this antigen is important for the recognition of cancer cells by the immune system. And so HR positive had the highest amount of human leukocyte antigen, while triple negative breast cancer had the highest amount of downregulation of this antigen. Another important agent that is expressed in breast cancer subtypes is the PD-L1. This antigen, this protein has been expressed greatly in triple negative breast cancers and less so in HER2 positive and HR positive. And this is an immune checkpoint agent that could be targeted by immune checkpoint inhibitors, which is being explored as potential therapeutic targets. PD-L1 positivity was associated with higher histological grades, lymph node metastases, and ER negativity. And finally, as cancer cells move from as cells move from a non-cancerous to a cancerous state, a lot of metabolic changes occur to meet the cell's energy and nutrition needs. And so therefore, in triple negative breast cancers, it was discovered that it had a lactic acidosis tumor microenvironment, and therefore a combination of treatment of lactic dehydrogenase with the anti-PD-1 agents, which I previously mentioned, is optimal for future testing. Another area of exploration is the ectonucleotidases like CD73 and CD39, which convert ATP into adenosine, which is an immunosuppressive agent. And because these are upregulated in triple-negative breast cancers, they are targeting agents that inhibit these molecules is being tested in vitro and in clinical trials. The second section of this paper discusses the extrinsic factors associated with the tumor immune microenvironment. And these extrinsic factors mainly are they're divided into two discussions. The first one is the amount of immune cells that are recruited into the tumor microenvironment. And even though in the past breast cancer was known to be a cold cancer, it doesn't have a strong immune response. Very recent studies showed that, in fact, on the contrary, nearly all immune cell types can be recruited in the inflammation response of the immune system towards the cancer. And triple-negative breast cancer, as I previously mentioned, has the strongest immune response, while the ER-positive luminal A has the weakest immune response, meaning the lowest number of cells that are being infiltrated. The second discussion about the extrinsic factors tackles the stromal components, which are the cancer-associated fibroblasts. These create an inflammatory response, and they recruit immunosuppressive cells like the T regulatory cells and the M2-like macrophages. They secrete signals that interfere with cancer cells, interfere with the matrix, and interfere with the number of immune cells that are being recruited into the tumor. And so in the triple-negative breast cancer, it was shown to this type of cancer had the highest stromal and intratumoral T-cell infiltration, as well as the peritumoral tertiary lymphoid structures, which are aggregates of B cells and T cells. And they have an increased number of immunosuppressive agents. So despite the fact that they have a high immune infiltration, this is countered by an increased immunosuppressive agents that will block these immune cells. And it is characterized by an enrichment in the cancer-associated fibroblast type 1 and type 4. For the HER2 positive, the extrinsic factors, it also has a high immune cell infiltration. However, it is more one way the immune system attacks this type of cancer is by targeting the HER2 receptor in particular. One immunotherapeutic option is the antibody-dependent cellular cytotoxicity, which uses a monoclonal antibody that binds to the HER2 receptor and recruits natural killer cells for the cytotoxic for killing the cell by apoptosis and other cytotoxic pathways. And another therapy is the TDM1, which combines this monoclonal antibody with chemotherapy. And the advantage of that is that the cytotoxic drug is going to enhance T-cell infiltration in order to improve the overall immune reaction. In the third subtype, the HR positive, in fact, here it's quite different because this subtype, in fact, has the lowest immune infiltration. And unlike HER2 positive and triple negative breast cancer, a higher tumor infiltrating lymphocyte were associated with poorer prognosis and worse breast cancer survival in that subtype. This subtype is characterized by the presence of M2-like macrophages, which are pro-tumor, they are immunosuppressive, they promote angiogenesis, tumor growth and invasion and metastasis. And in this subtype, it is the predominant cancer-associated fibroblast is the CAF type 2. This is a figure which is present in the paper that summarizes what I just said. Now, moving on from the molecular tumor microenvironment to the histological one, as I mentioned in the first slide, lobular carcinoma is associated with poorer prognosis. It represents 10 to 15% of all breast cancer subtypes. And the reason that it's associated with poorer prognosis is that it's diagnosed at older ages, it has larger tumors, and it has more tumor recurrences. So if we were, the paper compares immune lobular carcinoma with the ductal carcinoma, and it shows that the lobular carcinoma has lower tumor cell infiltrates, higher M2-like macrophages, and a greater stromal component. And the authors discussed that even though this type of the greater stromal component may block immune cells from accessing the tumor cells, this can be a potential target because the stromal contents, like the LOXL1, can be targeted by drugs to inhibit the tumor growth, evasion, and metastases to other places in the body. Again, this is a figure that summarizes the previous slide. And now I will be moving on to the final section of this paper, which discusses how these findings can be executed in treatment and promises effective strategies for breast cancer patients. So the first strategy that is suggested is combining the immune checkpoint inhibitors, which are being used currently, with other types of therapies like chemotherapy and radiation therapy. In order for the immune checkpoint inhibitors to be effective, immune cell infiltration must be high. And so the first way to increase immune cell infiltration is to combine these targeting drugs with cytotoxic agents, which is chemotherapy. And so cytotoxic agents have been proven in the lung tumors to turn or to convert poorly infiltrated tumor environments into highly infiltrated ones. And this high immune infiltration will increase the sensitivity of these cells to the immune checkpoint inhibitors. Another combination therapy is radiation therapy combined with the immune checkpoint inhibitors. Radiation therapy works in the same way in increasing the immunogenicity of the tumor and its recognition by the immune system. However, its mechanism is different in that it promotes mutations in the tumor cells to allow neoantigens to be expressed on the cells so that now they are better recognized by the immune system. A second suggestion that is explored are the adoptive cell therapies. These therapies involve the modification of T cells so that they are attacking particular and specific antigens. However, the limitation of this type of therapies, which include the CAR T cell therapy and the neoantigen-specific tumor-infiltrating lymphocytes, is that they are very time-consuming and they are resource-intensive, and they cannot be applied to all patients because it involves the removal of the T cells from the patient, their modification, and their reinsertion, which can cause problems, immune problems throughout this process. Another obvious and very direct strategy is to dampen the immunosuppressive response by targeting immunosuppressive agents like the tumor-associated macrophages, the myeloid-derived suppressing cells, the immune agents, which I discussed, the PD-1 and also the LAG-3. And also there's this agent, the CD47, which if it is expressed on cancer cells, protects these cells from phagocytosis. So an anti-CD47 therapy is being explored. And the final way to target cancer cells is to target their stromal components. It's important to mention, as the authors have said, that if there's a high stromal component in the tumor, this will block the drugs that are being used for treatment from accessing the tumor. And so the first very critical step is to remodel the extracellular matrix to change the shape of the tumor, of the stroma, to allow these drugs to access the tumor. Again, we can target cancer-associated fibroblasts by targeting the interleukin agents, for instance, in triple-negative breast cancer. And so the authors end by concluding that the previous monotherapies that have been used, like the anti-PD-1 and anti-PD-L1 targeting therapies, have been showing minimal benefits because they target only one aspect, which is the T cells. The authors suggest that other approaches that harness aspects of the interactions between the cancer cells and the immune response will likely be necessary, and that it is required to have distinctive approaches for each breast cancer subtype to ensure the best results. The authors suggest that animal studies need to be more utilized because they're currently underutilized in order to characterize each tumor subtype, its immune response, the signaling pathways, the receptors, and this can be done through sophisticated imaging and sequencing techniques and animal studies. So I'd like to conclude by saying that the significance of that study was that it kind of summarized all of the characteristics of each breast cancer subtype in order to provide better ways to target each subtype in particular to ensure better patient outcomes.